Hi, everybody. I notice a lot of very familiar names here this evening, and I notice a few new faces here as well, too. Welcome here to Luke's Legacy Family Research Rounds, which is a part of the Knowledge Mobilization Program with the Family Engagement Program, which is a 10-week course for researchers and parents to get together and learn more about partnering together in research. The reason why we started the research rounds is we wanted to have an opportunity to really offer information on new research knowledge to Canadian families and families from all over. And this whole event is dedicated on a monthly basis to my son who passed away in 2020. He was born with a very rare chromosome condition, and he was also a young man who was quite assertive and felt that he deserved a seat at every table. And so it's in his memory that we gather here this evening, and we are just very glad to have you here for such a very important subject. And at this point, what I'm going to do is hand the mic over to the team. I guess to start off with would be Dr. Tammy Dewan, whom I've known for a few years now and is a wonderful, very supportive person in this field. And I'll leave you all to it. Thank you so much for being here this evening.
Thanks, Ray, and a proud graduate of the Family Engagement and Research course, I would also note. Just recently, last iteration. Yes, very exciting. Okay, I'm just going to share my screen. So this always takes me a minute for some reason every time. So it's really nice to be here. We're so grateful to Ray and Kinga and the whole team at Luke's Legacy for this the invitation to present and be here with you today. We'd really like to talk about some work that we're doing in the space of medical trauma, particularly in kids who have more complex needs and with their families. I know this is a difficult topic for a lot of people, and so I just wanted to make sure that everybody feels safe and supported in this space. So I just welcome you to kind of come and go from the meeting as you like. And if anything comes up for you that you want to discuss, I'm happy to have discussion or questions or different perspectives introduced as we go along. So please feel free to interrupt me. I can get a little chatty, so also good sometimes to interrupt me so I kind of slow down and recenter a little bit. So I just wanted to make sure everyone was aware of that. The other thing that we really wanted to welcome as a team was for people to reach out to us after the fact. So if anything comes up for you that you wanted to talk about, we're also really happy to engage after. And we also have some really exciting opportunities coming up for people who are interested in staying engaged with our team. So you'll find our contact information at the end of my part of the presentation. So with that all in mind, I would like to, so I think some of us early on, some of people who joined early heard that the three of us are all joining from Southern Alberta. And this photo is very not seasonal, I apologize, but this was a photo from Bragg Creek. So in Southern Alberta, we're the traditional and unceded territories of Treaty 7. So that includes the Blackfoot Confederacy, which is the Siksika, the Piikani, and the Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda. The city of Calgary is also home to the Métis Nation of Alberta, Region 3. Just to give a bit of an overview of what we're going to cover today. So I'd like to start out with some introductions of our team of three. We'll then move on to a bit of a general discussion about what medical trauma is. And then I'd like to talk a bit about the research program that we have here at Alberta Children's Hospital and the University of Calgary related to medical trauma. I'm then going to hand the mic over to Christina, who's going to talk a bit about some of the patient and parent-led initiatives that have been taking place in Alberta, which are all very exciting. And finally, Megan Miller has joined us today as a clinician, a mental health clinician on our team, who's here and can also provide some practical advice to individuals and families who may be struggling with a medical trauma themselves. So just to start off with who we are and how we got here. So I'm the person in the middle with the two little munchkins who are undoubtedly going to make an appearance at some point or other. The first thing I'd like to say about myself is it just relates to my position in this space. So I am a pediatrician by training. I've worked in the healthcare system for upwards of 15 or 20 years or something like that. And I appreciate the limitations that this places on my perspective. So I'm very fortunate to have partnered with a lot of patients and family members and parents who have really opened my eyes to the importance of this work and have really, I think, directed a lot of this work. But I still feel that sometimes I have a bias that does not work in my favor in this space. So please please let me know if you noticed any of that, because I'm hoping that I am breaking through some of my professional boundaries. But I guess maybe more importantly, so I'm also a mom of two and came to Calgary about 4 years ago from Vancouver. I got into the medical trauma work really as a collaboration with one of my patient partners in Vancouver, who I know is not going to mind if I name drop her. So Isabel Jordan and I were co-investigators in some of the work that I'm going to present today. So she really helped me she really helped with both the inspiration for this work and has also been very engaged kind of driving this work forward, as has Megan. And Christina and I, interestingly, kind of came together. We were both kind of looking at this in different ways and have kind of come together around it very organically. So that's been also wonderful, if a bit later collaboration. So yeah, so my clinical practice is in hospital medicine and complex care in pediatrics at Alberta Children's Hospital. And with that, I will let Christina and then Megan introduce themselves.
Thank you, Tammy, and thank you, Ray, for having us today. So I'm Christina McGuire. I am first a patient myself. I am a parent to one medically complex kid and one who just likes to test all the boundaries. I have a lot of medical background. I grew up in a family of nurses. I eventually became a nurse in pediatrics and ICU and cardiovascular. So all that time, spent in the hospital and in and around patients and critical illness and so on, still did not prepare me for the journey that I'm on today. But that being said, I'm no longer a nurse, and I have been involved with quite a few projects as an advisor across, with our hospitals and across the province, and most recently have been looking at research in a different perspective other than just how it affects me. So I'm a graduate of the FER course and the Leadership Academy also. And those two things sort of set me up to be here today. I have a lot of lived experience that really doesn't know where to go. But putting it into a context here and for medical traumatic stress, it's something that touches my life deeply, but also I know it resonates with so many people. And I think that's why this community of researchers and patients and parents have come together, because no matter what the experience, the emotions are still the same. And that's why it resonates so much. So yeah, that's me. I can go into a little bit more later on detail about my kiddos, but right now I'll just pass it over to Megan. Megan, you're on mute.
Megan, are you there?
Yep, here I am. Thank you. Thanks, Christina and Tammy. Thank you for having me, Ray. I have a special connection to Ray because, of course, we knew her Luke very well here at Rotary Flames House. And as we were talking before many of you came onto the call, Luke has a very special place here in helping develop some policy and guidelines here at the house. I'm a social worker by background, and I've been working in the field of medical social work for about 25 years. These are my two very busy, active boys here in the picture with me. I started this job a long time before I even have kids, and one of the biggest transitions for me in my career was I think really coming to appreciate what it was like to work in a medical setting in pediatrics once I became a mom. Just appreciating the hopes and the fears and all that parents go through as they enter into any one of our systems in a very different way than I really had before doing this work without having kids, and knowing what that love and that attachment and that security was like from a parent perspective. So I bring a bit of my parent perspective here today, but also my experience as a social worker. The majority of my work falls in bereavement counseling. And through my work in that realm, I came to work with many parents who not only identified grief as their primary concern, but trauma. And the more and more I heard stories from bereaved parents, not just about their grief, but all the things that happened to them, whether it was acute medical event or a chronic condition that they journeyed with their child, or a traumatic event like a car accident, I learned that every parent had trauma threaded through their story. And one of my biggest pieces of learning in this work was often the highest degree of trauma wasn't rated for the time of death. It was rated for all different points in their journey, from the time of diagnosis to certain meetings where goals of care might have been discussed, right up until scary interventions or their child going for surgery, acute dips in their health, and so on. And so I started to really develop a curiosity and an interest, and became really passionate about working with trauma in a medical setting. How do we prevent it? How do we mitigate it? What do we do once we know it's happening? And so I was really honored when I first connected with Tammy around this research project, and just being able to engage and support from a social work and psychosocial perspective, all the wonderful work, the research that's being done on our site here. So thank you for having me.
So first, to kind of talk about what trauma is, I think everyone's, obviously heard this concept a lot in, if nothing else, at least in the media. I mean, and trauma can really refer to any sort of intensely distressing event. But when we hear that term, especially, in the media or in the healthcare setting, people often think about some of the more big dramatic events. So things like war and displacement, or conflict, or violent assault, or those sorts of things. And, I think it's important to acknowledge that trauma is a much broader concept than that. The other important thing about trauma is to talk about the symptoms around trauma. And we're going to get into that a little bit later. And then the events for trauma can be a single event, or it can be multiple or repetitive events. And the latter really fall under this concept of complex trauma, which we're not going to talk too much about today, but also is sort of going to be a thread that you'll kind of see weaving through a lot of our work, because the families we're working with do ultimately have repeated traumatic events. Slide, Kinga. Thank you. So really what we're going to focus in on today is this concept of medical trauma. So medical trauma has really only been talked about since about 2003. In 2003, a group at the Children's Hospital of Philadelphia coined this term and kind of described this model. And they actually termed it pediatric medical traumatic stress, or PMTS. So you might hear that term thrown around a bit. I don't love it. I find it a bit cumbersome. So I tend to shorten it to medical trauma, and I'm trying to be consistent in my terminology so as not to be too confusing. Medical trauma is really both physical and psychological responses to all the distressing and difficult things that happen in the healthcare setting. And you can see this can be things like pain and injury and illness, but it can also be things that, certainly as healthcare providers, things that we do. So medical procedures, treatment experiences that can be invasive, frightening, painful, all of those things. And what they were psychologist researchers, what they concluded about medical trauma is that it can result in a lot of the same symptoms as other forms of trauma. So both immediately while you're experiencing kind of an acute stress, but also later, kind of along the same realm as post-traumatic stress disorder. Symptoms like experiencing the event again through memories or dreams, or feeling hyper-aroused or reactive in similar settings. So all kinds of things can be sequelae of this concept of medical trauma. Slide, Kinga. So this is, sorry, Kinga, you're gonna have to actually, do you want to flip through like about 3 more times?
Yeah.
Just so I don't have to get you to do things a bunch of times.
Sure.
So this is the model that they came out with to describe this pediatric medical traumatic stress. And I'm sorry, it's not a very pretty model in my opinion, but there were a couple things I wanted to point out about it. So starting from top to bottom. So I think the point in the top of the diagram is that there's actually phases to this. So this peri-trauma is actually more, I think, accurately described as kind of pre-trauma. So what do people bring to an experience that impacts how they experience that event or what their reaction to that event might be. And again, for parents and parents who've been in the system a lot and kids who've been in the system a lot, they've often had very significant previous experiences. So it's not like they're coming to some of these events completely naive or cold to all these sorts of experiences. So that's the first phase. The second phase is what happens in the kind of acute medical encounter, the acute sort of traumatic event. And then the third stage is what happens afterwards. And this is often where we worry about symptoms becoming more chronic, more troublesome, more impairing and distressing and impacting, is when they're sort of lingering out into these spaces where people ideally would be recovering and moving back into their normal life situations. So that's the first point I want to make about this diagram. The second point is actually in the row below, and I'm also going to reframe this a little bit. So they call it subjective appraisals, but it's really about personal perceptions and experiences. And a lot of this relates to the emotional experience of an event. So when you talk about something being a trauma, especially a medical trauma, emotions like intense fear or helplessness, actually, and this will come out in some of our research, or uncertainty and the sort of fear and horror that kind of represents for people, all of that really plays into whether an experience is traumatic for someone. So I think that's a really important piece that hasn't always been a focus for, at least from the healthcare professional side of things. And then the third thing I want to draw attention to is just below. So you see these black lines in the middle of the diagram, and these are the different trajectories. So there's obviously stress involved whenever you have a child who's ill or injured. That's going to bring stress. What's important is how much stress is incurred, so how high that stress level goes, and also how long it lasts and what happens afterwards. And so the authors kind of go on to describe all the different kind of trajectories that can follow medical traumatic stress. When they developed this model, at the very bottom, along that bottom line, you can see this one little check, kind of a quarter of the way down, and that's the event. So one of the things that they've really conceptualized in this model is that there was an event. So often a single event, so like an acute injury or acute hospitalization for a child, that kind of sets this process in motion. One of the limitations of this model in its current form is, what about those people who are having repeated events? So again, kind of going back to this more complex type of trauma, where it's not a single event that you then sort of recover from or, kind of heal after. It's these repeated events that just happen over and over and over again. And so one of the things we've tried to do with some of our work is do maybe a more directed job at kind of fleshing out some of that. Okay, Kinga, it might make you click a whole bunch of times, but
okay, so just tell me where you want
until the next slide comes up. I apologize. Okay. Cumbersome. Wonderful. So this kind of led into our first couple of research questions. So I remember back, Megan and I actually had a conversation at the very, very, very beginning. So she was like the second person that I started talking about this with after Isabel. And one of the things that really came up, both coming from this healthcare provider background, was, do we even know what these events are? That was, I think, I don't know if Megan would agree with this. I mean, that was a really significant early realization for me, coming from my kind of position in the world, is that we may not even know what they are. So how can we possibly begin to address them? So that was one of the things we needed to know. The other thing we needed to know is what could be contributing to this that we might be able to move the needle on. Like, how can we improve care in a way that might mitigate some of this traumatic stress, knowing that there's going to be a lot of stress? So these were our first kind of couple of questions we wanted to embark upon. And this led into our first study, which was published in 2022 and actually is publicly accessible. So if anybody's interested in reading the whole thing, just type that into Google or type Dewan medical trauma and it should come up pretty easily. I mean, you're welcome to read the whole thing. So we conducted a qualitative interview study with parents of kids with medical complexity across the country. And we were really asking them, what medical trauma have you suffered? Can you tell us about it? Can you tell us how it impacted you and what contributed to it that you think we might be able to do a better job on kind of in a healthcare system? In this cohort of parents, the kids that they cared for had really high medical needs. So over 3/4 of them relied on some form of medical technology, and most of them had multiple hospitalizations, so upwards of 5 hospitalizations. And I will say, oh, thanks, Ray. I will say, again, just in terms of sort of where I'm coming at this work. So you'll notice, I think, as I talk about my research, that I focus a lot on this population of kids with medical complexity. And from my understanding and attendance at these rounds, I know a lot of you are parents of kids with medical complexity, and how we define that term, I think, is maybe less important. But what we're talking about is kids who have to be in the system a lot. So I'd like to really extrapolate or apply some of our findings to a much bigger group of kids than what we targeted for this study. I'll also mention that I tend to talk a lot about parents and caregivers, and that's sort of been where my research has sort of kind of gravitated to recently. But I know that like children and youth themselves also experience a lot of medical trauma, and Megan and Christina are both kind of poised to like jump in when I get too much into sort of parents and caregivers and stop and forget about the broader population and of course the important kids and youth. So, but just so you know that this actually is intentional, that we're focusing on parents and caregivers for some of this work, but there's lots of work left to do. Yeah, so slide Kinga, thank you. So this is sort of an overview of our results. So with all of our interviews, we came up with 3 what we consider to be main themes. And it really illustrates kind of the spectrum of medical traumatic experiences and the contributors to them that parents and families are reporting to us. Now, from bottom to top, actually, Kinga, you can click 3 more times and then everything will be up on the slide. So from bottom to top, we really found out that it's really at all levels that these contributors exist. So from the very bottom, the first theme related to the context of what it's like to be a parent of a kid with complex needs. And the level of stress that parents have, just having to sort of be in that role, but also having to kind of interact in a system that wasn't built for them, really is kind of poising people or putting people at, I think, particular risk of having medical traumatic experiences. So that was kind of our first theme. The other thing that kind of comes up in that theme, which I'll touch on a little bit more, is this kind of idea of having extremely high capabilities, like as a parent, as a caregiver, as a care coordinator, as all these things, but also having lots of responsibility and the kind of stress that incurs. So all of these are kind of elements of what makes it the unique context. The second level, kind of going upwards, is the second theme of this middle level of interaction. So interactions with healthcare providers and how those can be both helpful or harmful as it pertains to medical trauma. And we'll kind of go into that a little bit more. And finally, on the biggest kind of level of the system, it always comes back to the system. But the system really is setting the stage for some of these events to occur. And at the very least, it's not a system that is sort of responsive or even aware of the possibility of medical trauma. Can you go forward, Kinga? Thank you. So within each of these 3 themes, we actually came up with 3 sub-themes. So a total of 9 sub-themes. And I'd like to just review them because it really gives you a flavor for what the themes are actually about. I've presented a quote that I think illustrates each of these themes, but there's so many, it was almost impossible to choose. I'm not going to read the quotes out to you, but I encourage you to kind of read them while I'm talking, if you can kind of do a bit of a double thing at the same time. So the first sub-theme under the parent context is just related to these parent roles. So, I mean, this is not, sometimes I feel like I'm talking about you to you because all of you will know this so much better than me, but having to be sort of that advocate, that care coordinator, that medical expert. So, I mean, for a lot of our families in this study, they really serve that expert role, both expert in like what works for their individual child and sometimes expert in their child's disease, especially when it was quite a rare condition. So sort of the stress and tension that brings to that experience and that encounter in the healthcare setting, I don't think can be underappreciated, can be overappreciated. It's extremely important and part of what makes this such a unique experience for parents. Go ahead, Kinga. Thank you. The second sub-theme is related to parent expertise. So this is actually a theme that was universally reported by our study participants. This reality that when they did bring their expertise to the healthcare encounter, that it was often not appreciated, respected, incorporated, that they felt like it was dismissed. And The reason this was rendered traumatic is because, at least partially in some of our interpretation, that this makes the experience inherently unsafe. So sometimes it's actually occurred that something disastrous happened because the parental expertise was not recognized and incorporated, but at the very least that could happen. So a lot of parents were approaching this with a lot of dread and excessive stress and all of these sorts of things that kind of set the stage for trauma. Go ahead, Kinga. Thanks. And the third one is related to this balance of getting support from the healthcare system, but also having the autonomy to kind of do what needs to be done for your child and being able to exercise that expertise. And there was a few really salient examples that fell under this. And, so the first quote really talks about how, knowing a child so well and knowing what works for them and having that be able to translate that into the healthcare setting and all the conflict that creates with healthcare providers in the healthcare setting. The second quote relates to actually the opposite of that, of being kind of abandoned a little bit in the healthcare system in terms of making a difficult decision or not having the information, not having the support that you need to kind of make a decision or implement a plan or that sort of thing was another example. And the third example, which came up quite frequently, was parents being expected to do things like restrain their child from procedures and the kind of trauma that can be occurred by doing that and how that impacts again back on the parental role and not being able to sort of be a parent, but having to kind of fulfill these other roles. So those were the types of examples that came up under this one. Kinga, go ahead. If anybody wants to stop me, please just jump in. I know Ray will interrupt me if there's anything in the chat. So there's three sub-themes as well when we talk about interactions with healthcare providers. So the first one relates to trust. And I think, again, I think everyone on this call will be very much kind of appreciating this, but trust with healthcare providers when you're in the system isn't necessarily easy. It's not necessarily implicit or expected. It's something that has to be built. And I think one of the reasons for that came out in our study was that parents have often had quite negative past experiences. So things like misdiagnoses and medical errors and these types of things that, must be kind of addressed or dealt with in some way or potentially overcome in kind of building new relationships. So trust again relates back to safety, and everything that feels fearful and unsafe is going to be more trauma inducing for parents like those in our study. Go ahead, Kinga. Thank you. The next thing relates to communication and and the need to be sensitive in communication. And some of this relates to kind of the power of words. And one example that came out of our study was the power that certain words or phrases have for specific families. And one of the families in our study spoke so eloquently about how she reacted to the term failure to thrive. And, as a physician, this is a term that's just thrown about everywhere in the healthcare setting. We honestly don't think twice about it. But for her, especially with the word failure and some of their early experiences of kind of getting the attention that their child needed, really, it was all wrapped up together. And so that was a very triggering term for her. And I think there's lots of kind of examples of ways that we can address language and conversations and things like that either are or really are not working in terms of re-traumatizing families. Go ahead, Kinga. The last one is related to compassion. And, I think very sadly, from my point of view, like a lot of families in our study really had experiences where they felt like their child was experienced discrimination or lack of compassion because of maybe their disability or their condition or the frequency with which they require healthcare resources. But they really described that it was very painful, stress-inducing, unsafe, fearful experiences for them. The flip side of that, though, is also true, and I don't mean to paint everything in a negative brush. It certainly had some really positive, protective factors that came out, and one of them was experiences where people really felt that the healthcare team was compassionate to their child or individuals therein, especially in circumstances where someone had sort of gone above and beyond to do something for them, to do something for their child. And some of the parents really felt like that made, a maybe still traumatic experience, made it better, mitigated it, made it less kind of impactful for them. So I think there's lots of positive things we can focus on here as well. Go ahead, Kinga, thank you. And so our final theme being the system. So the first something that came out under the system was continuity. And I think the lack of continuity, again, was a real challenge that a lot of families faced, especially when they were describing some of their hospital-based experiences. Again, not having a relationship with a healthcare provider or a team looking after their child, not having that trust that we talked about before, really can impact that experience. And on the flip side of that, having a continuous provider, having someone you have a relationship with in the context of a traumatic or potentially traumatic experience did seem like it was also a protective thing. So that was something that parents really felt like could help, could move the needle, could make, these very difficult experiences you encounter less difficult to some degree, less stressful to some degree. Again, as much as we can do. Okay, Kinga, two more, I think, in this. So the next one that came up with hospital policies and procedures. So interestingly, we conducted this study right in the middle of the COVID pandemic. So I think we did most of our interviews during the first year of COVID. And this is the only area where COVID was really talked about. And I've heard a lot of families with our complex kids talk about how they had already been doing a lot of the things that we had to do during COVID. But I think as it pertains to the care in the hospital, I think a lot of families describe that as very difficult. This was an example of kind of policies and procedures that were developed that didn't take into account the potential trauma on kids, the potential trauma on families, the previous trauma on kids and families. And I think the other thing that came out was the rigidity with which these policies were applied, the lack of consideration for how some people's needs may be different or unique, or some admissions may be different and unique, especially when they were long or had lots of procedures or pain or those sorts of things in them. So this was something that really came out for a lot of people as well. And finally, the last one, which was also one of the universal reports from our families, was the need for better support and services, particularly for families and also for kids as it pertains to kind of mental health support and coping and those sorts of things, but really zoned in on the support for parents. And this is also related to kind of mental health support, potentially peer support. So different ways that we can support families to deal with what are going to be really difficult, traumatic, stressful experiences. And the fact that we often fall short in that realm in pediatrics, at least where we're working in our system. But the other things that this encompasses were even more what we consider basic things. So being able to get food and drink. And again, this was during the COVID pandemic when all the ward kitchens were closed. So not being able to even get food, get drink, get rest, respite, having volunteers or family members who could come and sit with the child and be with them while a parent, for example, took some time for themselves. So this was another thing that came out kind of loud and clear. You can go ahead, Kinga. So one of the questions that we couldn't answer with this study, but which was always in our minds, was sort of post-traumatic stress disorder, post-traumatic stress symptoms. A lot of our families in the course of these interviews reported these types of symptoms. Some have been diagnosed with PTSD in the past. You can click about 2 or 3 times, Kinga, to kind of bring up the rest of the perfect thing. Thank you. So just to kind of make sure everyone's on the same page about PTSD. So PTSD, of course, is a diagnosable mental health condition that comes after you've experienced or witnessed a traumatic event. So importantly, it doesn't have to be your experience. It can be something that you witness in a loved one. And the types of symptoms that indicate potential PTSD, and also that our families were reporting in this study, included all the sort of things that you see here. So trying to avoid places that remind you of the traumatic event, having difficulty with mood, with thinking, with concentration, and being reactive, being hyperaroused or anxious, all those sorts of things were our PTSD type symptoms. Go ahead, Kinga. So the next study that we kind of embarked upon is called Post-Traumatic Stress Symptoms in Parents of Kids with Medical Complexity. So what we were trying to do with this study was to actually get a sense about how prevalent is this in this population. So how many parents and family members are we talking about who might need more support, either prevention or treatment for PTSD or post-traumatic stress symptoms? So what we did was we enrolled parents of kids with medical complexity in the hospital at Alberta Children's Hospital, and gave them a survey that kind of measures how many post-traumatic stress symptoms they have. So the severity of them, whether they're in the severity of them. And with the next click, actually, Kinga, I can show you a little bit about who's in our cohort. So we now have about 72, I think, families enrolled. The numbers don't match up because everyone's at different stages of data collection. And we have mostly women, but we do have some men represented, which I think is important, especially in this type of work. Most people we've enrolled are biological parents, but there are some foster, adoptive, and grandparents represented as well. You can see the parent age and the child ages. Oh,
Sorry.
Thanks, Kinga. No problem. You're doing awesome. You can see the child ages is like 8 months to 18 years. So really spanning pretty much all of childhood. And then the other thing that we asked parents when they kind of came into our study was whether they self-identified as having a mental health condition already. And about 50% did, and this could be depression, anxiety, or PTSD. And for those of us who are kind of familiar with the literature on, health among caregivers and parents, I think that really is very similar to what others have reported, in that there's a lot of mental health symptoms and issues with people who have this degree of stress. Go ahead, Kinga. So I want to start out by saying that these are all interim results. So important to know that we haven't actually completed our study yet. We'll be complete by September. So this hasn't undergone full analysis or peer review. So kind of take it with a bit of a proverbial grain of salt, but I still wanted to share it because I think it makes some important points. So that little square graph on the left-hand side, each of those little blue dots represents the response to the survey. And the PCL5 is the name of the survey that we use to measure post-traumatic stress symptoms. The numbers on the y-axis, which kind of goes upwards, is the ratings on the score. So the score goes from 0 to 80. And you can see that we have people at 0 and we have people at 80. The orange line down the middle, or kind of close to the middle, around 31, that's the cutoff for whether somebody probably has PTSD or not. So in our cohort of parents, I mean, almost none of whom have actually been diagnosed with PTSD, we found about a third of them very likely do have PTSD. We can't say that based on something like a questionnaire, but it's a screening tool. So it does indicate that there's a lot of concern about those individuals in terms of what they may be suffering from. The other thing to note, which isn't shown in the graph, but there was about 20, I can't remember exactly, 25 questions, I think, on this questionnaire. And at least half of the parents scored in the severe range for at least one of those symptoms. So I think it's also important to note that even if people aren't meeting kind of criteria for PTSD, which was not developed for medical trauma, importantly, that they may still be experiencing some significant symptoms. So I think we need to also kind of broaden our minds to think about post-traumatic stress in a bit of a broader way. Okay, Kinga, thank you. So what can we do? So this is kind of where we're at now. So this just kind of shows my, rudimentary conceptualization of like what a journey is going to look like, because it's going to be a long journey, and you can have, early NICU stays, or even traumatic birth experiences, or even the when there's prenatal problems, like that increases stress, or even right from the beginning. Maybe you have a diagnosis of a new condition or a pre-existing condition kind of partway through, and then you have hospital stays and all these other interfaces with the healthcare system that really set the stage for this kind of ongoing medical traumatic experiences. Can you click again, Kinga? So I am a health services researcher. So when I look at this issue, I want to fix it from the system point of view. So I think about things like, well, we need to provide safer, better care for these kids so that we have less traumatic events to even worry about in the first place. Or we need to decrease family stress by providing, again, better care, better coordination of care, health services that are more responsive to kids with different needs. And then the last one, which I'm going to touch on a little bit, is we need to provide care that is trauma informed. And I'll go into a little bit more about what I mean by that. But can you click once more on this slide, Kinga? But the other way to look at this in a much broader way are more kind of individual and family level interventions as well. So things like, we need to increase awareness that this is even a thing. I think we're getting there slowly, but among healthcare providers, among patients, among families, everybody needs to know that this can happen and that this is something that we need to pay attention to. So I think that's one of the initial steps. Mental health support, I think, for patients, families, parents, everybody is in short supply and is going to be needed for some people who have this type of experience. And the possibilities around peer support, I think, are super interesting. Hasn't really been studied specifically related to medical trauma, but has shown lots of benefits in other areas. So these are the kinds of solutions, or not, solutions is definitely too strong of a word, but ways we could address this that we kind of talk about in our groups. Okay, Kinga, thank you. So I wanted to zero in on trauma-informed care, just so everybody knows what that is. Trauma-informed care is not a healthcare-specific concept. It's kind of across all service sectors. And this is a really, really awful definition. So I'm just going to summarize it verbally. So I think the important things about trauma-informed care is it realizes that trauma exists. It also comes from a place of assuming that everybody has trauma. So what used to happen is they used to talk a lot about screening for trauma, which makes everybody talk about all their horrible experiences again, which is actually completely counterintuitive. So now it's more talking about, let's just assume everyone has trauma and deal with it in that way.
I think the second part of trauma-informed care is recognizing when signs and symptoms exist and when people might need more help. So this is a bit of a screening exercise in the sense that you got to put support in place for people who need it or who are struggling. And the last bit is sort of responding at a system level. So taking what we know about trauma and integrating it into the practices in healthcare, other service sectors, so that we don't re-traumatize people and we don't contribute to the problem. Okay, just a couple more, Kinga. You're being so helpful.
Sorry.
No, sorry. You can go ahead.
No? Okay.
Yes. So very recently, I think last year, the American Academy of Pediatrics, which is one of our main kind of advocacy and governing bodies, it's American, but a lot of their stuff applies North America wide. So they've been talking a bit more about trauma-informed care, which I think is going to be very helpful to all of us. And this is just sort of how they've conceptualized it, which is very similar to what I just said. So the first element is to increase awareness. The second element is to recognize when it's happening and when help is needed. And the third is to sort of respond both at an individual level and at a health systems level. Okay, Kinga, I think just one or two more. Yes, so definitely easier said than done in terms of trauma-informed care. You can go ahead and click, Kinga, two times actually. Most healthcare providers really have very little knowledge or awareness of trauma-informed care. Unfortunately, especially in the pediatric sector, we are actually a little bit behind in this way. We recently conducted a survey of physicians at Alberta Children's Hospital. This was done by Dr. Susan Nechtel, who's one of our former trainees who's now on staff. And she found, you can see that on the kind of exam for trauma-informed care and what it is, physicians scored not too badly, 73%. So, B- or B+ or something. But when it came to their confidence that they reported in providing this care, there was only at 35%. So there's knowledge out there. It's just hard for individuals to put that into practice. So that's definitely a gap. One more click on this slide, Kinga. So also in the same questionnaire, so this was a fairly well-educated group as it came to trauma-informed care. So 65% had something before, so either a single webinar or a course or something. But 75% of them thought they needed more. So there's potential opportunities here to maybe build something that will be helpful for people. Okay, one more click, I think. Almost done. Okay, yes. So this is the question that we've landed on. And this picture was courtesy of my 7-year-old this morning who wanted to draw me a picture of Alberta Children's Hospital that we could use. So that's what our hospital looks like, kind of. So how do we actually address medical trauma in the system? Because the other limitation with trauma-informed care is it was really designed to apply to trauma that occurred out there. Childhood trauma, early childhood issues, so trauma that was not kind of healthcare related. Whereas I think what we really learned is that so much of the trauma that the children and families have is actually within the system, that there may need to be things that change that are quite different than what we talk about with traditional trauma-informed care. Okay, one more click, Kinga. So we have some really exciting opportunities kind of coming up. We actually just found out this morning that we got a grant with which Ray and Christina are both on with me, that we can do a co-design project looking at developing a trauma-informed care-based intervention specifically for medical trauma, which is very exciting. So if anybody thinks that sounds cool or interesting, feel free to reach out to me or Christina. This will be kind of Alberta-based, but I think we're also really interested in just staying in touch and collaborating with people who are also interested in this work. If you want copies of the papers, or if you want us to just send you results of the PTSD study when it comes out, just drop me an email or find me on Twitter, and I'd really be happy to connect. I have talked way too much. Christina and Megan are both so wonderful and have so much to say. So I am done with the slides, and I would welcome Christina to start talking, to take us through a bit of her experience and opportunities.
Thank you, Tammy. And you didn't talk too much. It's a lot to it's a lot to explain, to go through. And I was saying before, like it's very familiar, which is which is unfortunate. I think that we are at a really good position to start this work, considering that we've had so many people who have been touched by a little bit of that sort of trauma, that medically induced trauma, because of COVID. So it's whereas it may not have been on the table for conversation before, it very much is now. But in my experience, it's always been on the table. And I think because I I knew as a patient, myself, a pediatric patient growing up, knowing sort of what types of things can linger in your memory and in your body memory and that sort of thing. I was always very aware of how I was parenting my kids. And so also being a medical professional, I wasn't afraid to advocate in those spaces. So, I knew that in some circumstances in the adult world, we would, be checking the Ativan and the Medads at the adults who are going to get, an ingrown toenail cut out. And yet it was still really minimal and really not even offered for pain control or comfort measures and those types of things for pediatrics. So when my son was born, we didn't know his diagnosis. So I had a really lovely pregnancy. I would have been one of those moms who were shipped off to another hospital to give birth because of his heart condition. And so I've spoken with friends of mine who have had that experience, have had that trauma sort of in the very beginning before they even became a parent of the child. And then those who, obviously have had traumatic experiences with their kids, having, critical brain injuries and that sort of thing later on in life. So the thing is that these types of emotions are still across the board. For me, I was very lucky to have some nurses and doctors who were ready and willing to sort of share what I could do as a parent and put me in touch with things like child life and starting therapy early. When we were talking about words that sort of trigger, I mean, I heard heart failure on a daily basis, and that wrecked me. And at the same time, I was very cognizant. My daughter, who was 3.5-year-old when my son was born, heard everything, saw everything, absorbed it all. So I knew that as an infant, my son wasn't really dealing with any of that at the moment, right? It wasn't going to be sort of imprinted in his memory at that moment. But my daughter, however, was vicariously traumatized by being taken to the ICU and watching her brother be resuscitated and those types of things at a very young age. So we incorporated therapy and using the language sort of immediately. And I think the way that I approached it, the physicians and the clinicians and the child life specialists, they saw how important it was to me. So I have been very lucky to have a lot of people on that team who are going a little bit above and beyond. But the fact is, there's still a significant amount of trauma. And whether or not they mean to or not is, that's not really the point. The fact is it's there. And so the little things that we can do to sort of mitigate that, right? Like, let's not even start that conversation that way. Let's begin way before we get to that point. So learning those sort of tips and tricks and talking it out, and really reaching out to a lot of the doctors and saying, look, I know this is going to be part of his life. I know we cannot change the circumstances. We can't change what's going to happen, but how do I prepare him for a lifetime of this? And I was very lucky to just recently do a sort of a storytelling workshop with adults with congenital heart disease. And so these are young adults who have transitioned into care. And again, hearing their perspective and their memories and their, those core memories that they have, and how much it affected them and how it imprinted on them and affected how they grew up and their self identity and even just their future. It really was eye-opening. So I think this work for me is so important because trauma is everywhere, but there's trauma that can be prevented, mitigated, and at least we can do tiny things, language change, preparing choices. That was always the big thing. I always said to the doctors, before you walk into this room and you lay your hands on him, you need to tell him who you are, what you're doing, why you're there, tell him a joke even, right? Break the ice. And that made a huge difference about how he interacted with those providers. So yeah, there's so much more we could talk about, but I want to give some time to Megan to share a little bit about what she's seen as well.
Thank you, Christina. I think you and Tammy did such a beautiful job of setting the stage for our work and your personal experiences and some suggestions from the system level right down to the family, patient, and individual level. So I think much of what I have to say just affirms everything that you two have already really articulated. One of the things I've noticed in my work, and again, I work in palliative care and I work in bereavement. So my greatest learning comes from working with parents, and my experience is more working with parents than the children themselves. So that's my lens I'm speaking to you from today. Parents have an incredible ability to hold a lot of trauma. I don't even know, I see head shaking, nodding. I don't even know if you appreciate how much trauma you may have experienced and held. You hold this capacity, and in that, I think for some, it becomes normal. It also can become minimized. It also can become disenfranchised. Like, I've been in this work for a long time, but I've only started talking about trauma, I'd say maybe in the last 10 years or so, because it just wasn't part of our training. And as a medical social worker, it wasn't always part of the lens that we look through, which is incredible to think back now how much we missed. And I just encourage parents, healthcare providers, caregivers, really listen to that gut. You know when something isn't right. You know when your nervous system is reacting to something, right? It might not even be an intentional conscious cognitive thought. It may be something you're experiencing deep at the core, deep in that nervous system. Trust what you're feeling. Recognize the signs of trauma. Recognize when you're feeling out of that window of tolerance, that fight, that flight, that fawn response. Name what doesn't feel safe. And that might be, as Christina mentioned, language. It might be a term that a physician or care provider is using. It might be a tone they're using with you. It might be something you're being asked to do, or a topic you're being asked to talk about in a meeting, or a decision you're asked to make. Identify for you, for your family, what creates safety. What creates you feeling like a good parent, a good mom, a good dad, a good caregiver? Focus on the relationships with the healthcare team. We know that trauma breeds disconnection, right? When we're traumatized, we might feel betrayed, we might feel distrusting, we might feel angry, disconnected. We're not feeling safe. But we know relationships within trauma are our biggest agents of change. Finding that one person that can acknowledge and help you name those traumatic experiences. It might be a whole bunch of little ones, it might be one huge one. Find that person on the team that can help co-regulate you, right? When we get distressed, when we get offline, when we don't feel safe or our bodies don't feel ourselves, when we have that one person on the team that we can trust, their regulated nervous system can work to regulate ours as parents in the system. Finding that one person, that support person, that advocate, that trauma-informed person on the team. Work for shared decision making. I think one of the things I often hear from parents is the guilt they feel around decisions that they made. And even though there's a whole team involved, parents step away feeling they made the decision to stop at that number of chemo treatments, or they made the decision to wait on that surgery, or they made the decision to have care at home at end of life as opposed to the ICU where more interventions could be used. And I think in terms of our role as healthcare providers, sometimes we move on that spectrum from team focused decisions to family centered decisions. And sometimes parents even feel that one step further where they feel the decision was put on them. I love when parents feel it was shared decision making. And even in some cases, we need when there aren't decisions to be made because of a particular diagnosis or prognosis, when the team steps up and takes control of that decision making, that can alleviate some of that guilt for parents. We know trauma occurs not just in events, but also in communication, in conversation, in decision making. And as Christina mentioned, find the things as parents that we can control in a setting that we probably often feel we don't have a lot of control around, but it might be little things from where we meet. I worked with one family that every time they were called into the ICU conference room, it was never good news. And it's got to the point where this mom started avoiding coming to the ICU. She stopped coming to meetings. We would plan meetings weeks in advance, and she would stop coming because that room itself, before a word was even spoken, was so triggering to her. So if you can control what room you're meeting in, if you can control who's there, are you a parent that likes everyone from all the teams there contributing and dialoguing and supporting? Are you a parent who feels safer with one support person and your primary physician? The content of the meetings. I know for some families, often we bring them back in several times because maybe they didn't understand the first meeting, or they didn't arrive at a decision that maybe they feel the team wanted them to get to, a decision around surgery or a decision to modify goals of care. And so often I hear from families like, we've already had this conversation. We don't need to have this again. I've already shared with them what we value, what our wishes are, what we want for our child. And so there's little ways, even in these huge systems that often need a huge culture shift and a lot of work to support our trauma-informed care, there's still little things that I hope you feel empowered to do and ask for to support yourselves. Self-care, of course, and treatment that specializes in trauma. And I know we're not great at that. It's been identified already that our system, we're moving towards and we're creating more awareness around the need for it. I know we are all committed to trauma-informed care, but ideally I want to see that even taken one step further. So when us as a system creates trauma in parents that we're working with, parents and kids that we're caring for, I want to see us take the responsibility and being able to offer those supports that allow the treatment of this trauma. And we're starting. I know in social work, for example, at the Children's Hospital, we have a very dedicated group. Some of us are trained in specific trauma interventions like accelerated resolution therapy or EMDR or prolonged trauma exposure. Some are not, but out of that group that's not, they are identifying that as professional development need. They are identifying that as a gap in our learning and in our abilities, and they are asking for more supervision, for professional development to be able to offer that. I know a long time ago, our focus in medical social work was supporting families with the immediate need they had while they were in hospital. But we now have outpatient clinics and outpatient psychology and social work that's able to extend outside of inpatient admissions and ED admissions to provide ongoing support to families. We also know about community resources in our area, as well as peer support, which was mentioned earlier. I know that in just the programs I work in, we have a Facebook group for bereaved parents connected to our hospital. As well, we have a Facebook group for parents connected to Rotary Flames House who have children who have a diagnosis, which may be palliative and complex. And our hope is that families are engaging outside of the professional support, because we know that's just as important, if not more important, to have that peer support as a way to have that trauma recognized, validated, supported. And we know the value in sharing those narratives and sharing those stories parent to parent. So we know there is so much work to be done. We hope that you can continue to find little small ways to teach us, to remind us how we can better support, mitigate, and prevent trauma in our system. And I hope on a system level that we can continue to work with you parents as our guides and as our best teachers to change our culture and to change the way that the system supports, mitigates, and prevents trauma. Thank you.
Thank you oh so much to Tammy and Christina and Megan for your incredibly informative talk here this evening. I know that I've learned a ton this evening, and I'm just so grateful for that opportunity. And I look forward to sharing this with our larger community online through our YouTube channel as well too. I just wanted to take a moment to close up the evening, but also to inform people, number one, we noticed over time that people were looking for an opportunity and an outlet to have conversations afterwards with these events. And so we just wanted to invite you, and there's no pressure for anyone to stay for the next half hour to come and hang out and have an informal chat. That will be slightly moderated by me. You are welcome to stay if you like. On the other end as well too, I just wanted to mention as well for you to be mindful of the experience that you had this evening. A lot of times in taking information like this, it kind of works much like self-regulation in the brain and things like that. You have something you love, for example, like a cup of coffee. I have a particular mug that I like, and there are various aspects. It's the right size, it's the right fit. It's lovely when I have the right sort of beverage in there. All of these things help my brain to seek comfort in that particular item. You take one aspect of that away and the brain starts to go, in that moment. And so I just want you to be aware of that. You might see some energy that you feel a little bit uncomfortable, a little bit anxious, things like that, that might even drift into the next day. Please find ways to take care of yourself over the next 24 hours as you do that. It's something that is difficult to know whether or not it's going to happen, but when it does, you just want to be prepared for it and be aware of exactly what that is. For my own experiences giving talks, I suddenly realized at one point that having post-traumatic stress, there was going to be opportunities where I might cry, and that is just my body and my brain doing what it does. But I also needed to share and convey to other people what to do in this moment. I did not need hugs. I am not a hugger in those moments. I will collect myself. But I also don't need life advice. That's okay too. So a lot of my talks beforehand, I share that as an opportunity just to say, like, if this happens, it's okay. Let's normalize this as a part of what we all go through. So please take care of yourself this evening.